Greetings and welcome to this clinical pharmacology series. In this video, we'll discuss about the antibiotics. I will discuss about penicillin and piperacillin-Tazobactam from a basic overview point to the in-depth perspective. Currently available penicillins are Penicillin G, Ampicillin, Amoxicillin, with Sulbactam, without Sulbactam, and Piperacillin-Tazobactam. These are the commonly used penicillin group of antibiotics nowadays. So we'll discuss about the mechanisms, spectrum, dosing, and ICU pulse of penicillins and Piperacillin-Tazobactam. So if you're new to this channel, do subscribe. Let's get started. This is Medicine Beyond Harrison's. So penicillins still matter. These are the oldest beta-lactam groups of drugs, yet clinically indispensable. It has a very narrow spectrum of actions with excellent stewardship tools. So it is a first-line definitive therapy for many pathogens. It also is nowadays used as an ICU workhorse drug. Mechanism of action is beta-lactam antibiotics bind penicillin binding proteins, inhibit cell wall synthesis, and it is bactericidal. This is the most important concept that you must take away from this slide. There's also time dependent killing. So the amount duration the antibiotic is there in the blood above the minimal inhibitory critical concentration. That's when the action is better. So resistant mechanisms are too much for these penicillin groups. Beta lactamase production can be there. It is an enzyme. Altered penicillin binding proteins so that these penicillin drugs could not bind to that protein and reduce permeability in case of gram-negative bacteria. Contraindication is mainly this beta-lactam allergy. It will cause rash, anaphylaxis, interstitial nephritis, hepatitis, and drug fever. So true IgE-mediated allergy is common, but it is very serious. So always ensure to give one test dose before giving a beta-lactam drug. So drug-drug interactions, probenecid impairs renal tubular secretions, increases penicillin G levels. So probenecid nowadays is not commonly used. Anyways, it is a very important drug-drug interaction that you must remember regarding penicillins and probenecid. And again, there is increased risk of macropapular rash with ampicillin and amoxicillin. So avoid alcohol together when you are giving ampicillin or amoxicillin. Mycophenol bioavailability is reduced due to amoxicillin. With antacids is reduced with amoxicillin because of high gastric pH. So you must ensure to give amoxicillin either after food or without a proton pump inhibitor. Side effects at high doses can cause neurotoxicity, which is myoclonus seizures and confusion. One of the most pro-convulsant beta lactams is penicillin G. So penicillin G is nowadays commonly given as deep IM injections with a large dose, 1.2 million units, mainly for syphilis and other infections of gram-positivity. This can cause seizures, confusions, and myoclonus. So always be aware of the neurotoxicity of penicillin group of drugs. Again, it can cause anaphylaxis, thrombocytopenias, neutropenia, hemolytic anemia. So both ceftriaxone, which is third generation cephalosporin, as well as penicillin G is very prone for causing hemolytic anemia. So be careful of this. There is false positive Coombs test also. Ampicillin and amoxicillin are comparatively better tolerated than direct penicillin G. It can cause macular rash. Just ensure that you don't deal with an EPV infection. That's mononucleosis. Whenever a patient comes to you with sore throat, lymph nodes, try to avoid amoxicillin or augmentin because in case if it's an infectious mononucleosis, there is high risk of macular rash. So ensure to avoid amoxicillin when you suspect an EPV infection. Again, when a patient is on having CLL, HIV infection, allopurinol, again avoid amoxicillin. It can cause macular rash. And a few organ-specific side effects. So this kidney, it can cause acute interstitial nephritis. In case of liver, it can cause cholestatic hepatitis. So one of the most notorious drug which can cause cholestatic pattern of liver injury is amoxicillin. Again, it can cause neurotoxicity and also cause renal failure. So systemic side effects such as cytopenias are very, very common. Drug fever can happen and nausea, vomiting, diarrhea can also happen. The ampicillin sulbactam similar to ampicillin, but there is increased risk of cholestatic hepatitis. So always ensure to take an liver function test before administering ampicillin sulbactam, and always ensure to check again in third day or fourth day after initiation of ampicillin sulbactam. So often delayed 6 weeks post therapy also it can happen. So it is usually self-limiting. So penicillin G misses MSSA, which produces penicillinase enzyme. So whenever you suspect a skin and soft tissue infection with MSSA organism, try to avoid penicillin because penicillinase enzyme is produced by MSSA, so it can lead to decreased sensitivity of that organism. So otherwise, it covers most of the gram-positive organisms, such as Streptococci, Group A, Group B, Group C, and Group G. Staphylococcus pneumonia is also penicillin sensitive. Neisseria meningitis, Clostridium infection, not Clostridium difficile, and oral anaerobes, orally present anaerobes, and Listeria monocytogenes and Treponema pallidum. So syphilis is the most commonly used use case of current generation for Penicillin G. Otherwise, better drugs are available for coverage of all these organisms, so it is not the first line nowadays. So rarely empiric, definitive and susceptible only for Streptococci, Penicillin Streptococcus pneumonia, Neisseria, Clostridium perfringens, and Syphilis. So zone is preferred for CNS despite penicillin sensitivity because it is easier dosing. So nowadays we prefer ceftriaxone instead of penicillin G for most of the use cases except for syphilis. When compared to ampicillin, penicillin G has very low MIC, so remains active even at low levels. It has a great track record against endocarditis, meningococcemia, Clostridial infections, and syphilis. So ampicillin is again a broad spectrum, similar efficacy for susceptible organism, but no strong evidence for persistent selection also. So in fact, nowadays ampicillin is preferred. It is a better drug compared to penicillin G. So ampicillin and amoxicillin spectrum, again, these are not so active against MSSA organisms because of production of penicillinase. So ampicillin now use case is mainly against Enterococcus faecalis. Again, for faecium, it can be used when it is a susceptible organism. So excellent coverage against Enterococcus faecalis is ampicillin. It can also be used for Streptococcus, penicillin sensitive Streptococcus pneumonia and Listeria. So currently, the main use case of ampicillin is against Enterococcus faecalis. So gram-negative, it has a variable penetration and susceptibility. So try to avoid ampicillin when you suspect a gram-negative infection. Again, with E. coli, it is 65% sensitive, and for Proteus, 85%, Haemophilus influenza, 70%, and Neisseria, Lyme disease also, ampicillin can be used in specific use cases when it is susceptible. Current indications are non-virulent cellulitis for ampicillin, pharyngitis, bacteremia, meningitis, and UTI. Drug of choice for Enterococcus faecalis and Listeria. So, for Listeria, it is even better than meropenem for ampicillin, and again for Enterococcus faecalis, it is susceptible. This is the best drug that you can give. Amoxicillin can be used for oral step down of ampicillin. It has a better bioavailability, less frequent dosing can be given. Again, Ampicillin Sulbactam spectrum is again MSSA, Staphylococcus staphylococcus, and Streptococci improved for Enterococcus faecium. When combined with Sulbactam, it has a better than just for Ampicillin, best for Klebsiella and Proteus. Again, it is inferior to Streptococcus and bacteremia. Excellent coverage against anaerobes, especially these Bacteroides fragilis. When combined with Sulbactam, you can use it for MSSA organisms also. Use case of Ampicillin sulbactam is now for epiglottitis, ENT infection, community acquired empyema, zoonotic infections, human animal bites, and mild ablic. Main use case of the sulbactam is used against Acinetobacter baumannii. Sulbactam is active and combined with ampicillin, there is more susceptibility and beneficial effect for treatment for Acinetobacter. When dosing is, this penicillin dosing is again in million units. So when the GFR is more than 50, it is given as 24 million international units per day divided in Q4 to 6 hourly. Severe endocarditis CNS infection, 4 million units, Q4 hourly it is given for enterococcal endocarditis, 18 to 30 million units per day. So 1 million unit is 600 milligram. So GFR, when it is 30 to 50, reduce the dose to Q6 hourly. If it is 10 to 30, you can go up to Q8 hourly. If it's just less than 10, you can go for Q12 hourly dosing. So again, it is a very high pro-convulsant drug at high doses, penicillin G. So try to avoid when there is susceptibility for seizures and low threshold for seizures. Ampicillin, we all know it is a 2 gram dosage. 2 gram IV Q4 hourly is the commonly used dosage for meningitis, endocarditis, enterococcal UTI. All these things, this is the commonly used. Use upper limit 2 gram Q4 hourly. Renal adjustment for GFR less than 50 you can go for Q8 hourly, and less than 30 Q12 hourly, and less than 10 or 12th hourly or 16th hourly. So, however, it is based on the GFR, you have to titrate the dose of ampicillin. Ampicillin sulbactam comes as a combination of 3 gram dose. It is given Q6 hourly. Ampicillin is 2 grams and sulbactam is 1 gram. According to IDSA 2023 for Acinetobacter, carbamazepine and Acinetobacter, this 9 gram Q12 hourly of sulbactam and ampicillin sulbactam is the standard infusion of choice, and it is given as a 4-hour infusion. So, ampicillin sulbactam again, it is dose is modified in renal dysfunction. For less than 50, you can go for Q8 hourly, less than 30 Q12 hourly, and less than 10 Q24 hourly. Amoxicillin high dose is given for step down for gram-negative bacteremia and community-acquired pneumonia with DRSPRS. For all these cases, it is 1 gram Q8 hourly and 150 milligram Q6 hourly. This is the commonly used dosage. The absorption is saturable at 70 milligram. Q 6 hourly may be better. So 70 milligram Q 6 hourly is a good dosing pattern compared to 1 gram Q 8 hourly. For renal and standard dosage is 250 milligram, 10 milligram Q 8 hourly for UTI and cellulitis. In case of renal GFR more than 30, you can go Q 8 hourly dosing itself. For GFR less than 30, you can go for Q 12 hourly. So penicillin G is protein binding is almost 60 percentage with a volume of distribution of 0.3 liters per minute, which is pretty moderate with a half life of very short, less only 20 to 50 minutes. With excellent CNS penetration, when it is inflamed, again can cause seizures due to this pharmacokinetic property. Ampicillin Sulbactam has wide penetration, CSF of 30 to 35%, 40 percentage if inflamed. Renal elimination is almost 85 percentage. Amoxicillin has CSF penetration but has a very good oral bioavailability of 80%. Now coming to the main ICU workhorse drug, that is the Piperacillin-Tazobactam. It is an extended spectrum uridopenicillin group with a BLA combination. It is not a carbapenem substitute for ESBL bacteremia. So keep in mind when the zone is resistant, you suspect a ESBL organism. Even though Piperacillin-Tazobactam is sensitive, don't go for Piperacillin-Tazobactam. You can go for meropenem for treatment of ESBL bacteremia. Again, for few susceptible ESBL organisms, when the MIC of Piperacillin-Tazobactam is less than 4, and when the patient is not in shock and uh, when the patient is not immunocompromised, you can in that specific use cases you can go for piperacillin-tazobactam. So contraindications and interactions to piperacillin is again allergic to piperacillin, tazobactam, sulbactam, clavulanic. Any allergy, try to avoid piptas. Interactions non-depolarizing paralytics like prolonged neuromuscular blockade. In case of propanacid, there is increased drug levels. When combined with methotrexate, there is decreased clearance and tubular completion for piptas. So side effects again, pseudo-nephrotoxicity, increased creatinine due to tubular secretion inhibition. So it is not a true AKA. So wait for the AKA or increase in creatinine to settle once you stop the drug. General toxicity is always present for other as for other antibiotics, such as GI upset, rash, fever. Drug fever can happen. Neurotoxicity, renal failure in case of renal failure patients. Cytopenias on more than 21 days usage, increased PTI and renal failure. Clostridium difficile versus Cefepime. So there is decreased Clostridium difficile when compared to Cefepime. Plus spectrum and uses. Spectrum is MSSA organisms and Streptococci and Vancomycin sensitive Enterococcus. All these cases you can go for Pip plus. Again, Pseudomonas is a very good drug to cover for Pseudomonas. Central bacteria are susceptible for Pip plus. Anaerobes, except for Clostridium difficile, you can go for Pip+. Again, ceftriaxone resistant but Pip+ sensitive gram-negative organisms such as ESBL. In these cases, go for carbapenem and then Pip+. So use cases is specifically is for septic shock, intra-abdominal infections, biliary sepsis, urosepsis, and nosocomial pneumonia, neutropenic fever. All these cases, this becomes the first line of antibiotic of choice. So takeaways for Pip+ dosing if more than GFR is more than 20%. It's given 4.5 grams Q 8 hourly with extended infusion of 4 hours. And GFR is less than 20, 4.5 grams Q 12 hourly. And augmented renal clearance, it is given as Q 6 hourly. In case of CRRT load, which is 4.5 grams, go to 3.375 grams to 6.5 grams Q 12 hourly. So in case of obesity, you can go for Q 6 hourly dosage. So one final take-home point is penicillin G is a definitive therapy for many organisms, especially for syphilis nowadays. So it is a antibiotic with the specific use cases. Ampicillin mainly for Enterococcus and Listeria. These organisms which Ampicillin is the champion. Ampicillin Sulbactam mainly for Acinetobacter, human bites, animal bites, anaerobes. Thus, it is an ICU workhorse. It is a cure drug for non-ESBL gram-negative organisms. We learned a lot on this video on penicillins and Pip-Tazo. So, if you are new to this channel, do subscribe. I will discuss more about this antibiotic series and clinical pharmacology in this video. This is Medicine Beyond Harrison's. Thank you for watching.